welcome everybody. This is the Retina UK information webinar. This is one of a series of webinars we're hosting and we deliver one most months on a different topic. My name's Kate Arkle. I'm the Research Development Manager at Retina UK. In today's Ask the Expert session, we're really pleased to be joined by Samantha de Silva. Sam is a consultant ophthalmic surgeon at Oxford University Hospitals NHS Trust, and she specialises in retinal conditions. And she'll be answering your questions this evening. My colleague, Jane Russell, who is our communications manager at Retina UK, is also here in the background, and she's going to be helping out with managing questions and the tech side of things. We have received quite a lot of questions in advance, so we'll be working our way through those, and thank you for sending them in. If you haven't already asked your question or you think of one during the session, you can type it into the Q&A box in Zoom at the bottom of your screens, and those questions will then be asked by me or Jane on your behalf. We will endeavour to answer as many questions as we can. However, any questions that we can't get to today will be followed up over the next couple of weeks. If your question hasn't been answered in a couple of weeks' time, do feel free to get in touch with us. So last week was National Eye Health Week. So let's begin with a couple of questions about general lifestyle and eye health. So Sam, what are your top 3 lifestyle tips for supporting overall eye health if somebody's living with an inherited retinal condition?
Well, thank you, Kate, for the invitation to join this webinar. In terms of the top 3 things, I think the number 1 by a long way has to be to stop smoking, because really, if you look at all the evidence from multiple different trials and different eye conditions, so age-related macular degeneration, diabetic retinopathy, but also the few studies that there are in inherited eye disease, and an inherited or genetic disease does tend to be the least well researched out of most retinal conditions, given that it, overall is probably one of the least common. But all of those consistently show that smoking is bad for your eyes. So either causing earlier onset disease or more severe, progression or more severe disease. So the number 1 thing, if people smoke, I advise them to try their very best to stop smoking. And obviously that can be difficult. It's not a straightforward thing of just walking out the clinic door and stopping, but there is a lot of support and a lot of help out there to help people do that if they want to go down that route. So you can get referred to your GP for smoking cessation support, and there are sort of programs to help with that. So so definitely, I would say that's number 1. And sort of the second thing we always mention is diet. Really not, again, because there's a huge amount of evidence in RP or in retinal dystrophies, but just looking at more broadly eye health and retinal disease. So the general advice we give is eat a healthy, balanced diet. So lots of highly coloured fruit and vegetables. So sort of bright, bright things, red peppers, kale, carrots, even egg yolks and things like that have are beneficial. And really, there's no specific one food that is necessarily a superfood for the retina, but just eating a good balanced diet with, if you can do your 5 fruit and veg a day and all that, the usual recommended things that we should be ideally doing, then that's really good enough. And then the third thing that we always mention, because it's an easy and straightforward thing to do, is UV protection. So if it's a bright sunny day, wear sunglasses or a wide-brimmed hat, because we know that ultraviolet lights can be toxic to the retina, can be harmful to the retina. And so if it is particularly sort of sunny, then do wear sunglasses. I appreciate that can be difficult when, if you have RP, then obviously you don't want to cut too much light out, because then that can make navigation difficult and so on. But it's finding that balance of you know, on a very, you know, dazzling day, then do wear that protection.
Brilliant, thank you. And related to that, we get a lot of questions. We've had a lot of questions about supplements. So to clump all of that together, are there any nutritional supplements that people should be taking or shouldn't be taking?
So for most retinal dystrophies, really, again, there's not a lot of specific evidence looking at nutritional, you know, any nutritional supplementation. Over the years, there's been a lot of discussion about vitamin A. So there's vitamin A in RP and there's vitamin A in Stargardt's, which are two sort of different issues.
Yeah.
So if we think about vitamin A in RP, this essentially all came from a big study from a group from Berson's group, who's a very eminent physician, sort of about 20 or even 30 years ago now. And what they looked at was vitamin A supplementation in RP and whether that would affect progression. And given that, and it's very, so they did show that there was a beneficial effect, you know, in that study probably 30 years ago now. But it's difficult to know how to interpret that, to be honest, because one, it's never been replicated again. And secondly, they used, the things they looked at were things that were that we now think are quite variable, such as visual field tests, to look at outcomes. So nowadays in modern clinical trials, we would use things like you know, imaging OCT scans, you know, very objective measures to look for a treatment effect or not, whereas the things they used were more like visual fields and electroretinography, so electrophysiological testing, which can be much more variable. So and there was a big Cochrane review subsequently looking at all of these things, and the sort of overall evidence was not really in favor, not harmful, but no clear benefit. And so we've really moved away from advising people to take specific supplements if they have RP. So really the evidence I give my patients is what we've sort of said before, to have a healthy, balanced diet and do those, you know, just the usual lifestyle measures. You've obviously got a separate question of vitamin A and Stargardt's, which is sort of a different thing. And essentially in Stargardt's, because the ABCA4 gene is involved in transport of that, the visual cycle of which vitamin A is a part, there's a lot of laboratory work that indicates that, you know, too much vitamin A is detrimental and is hard to process by the retina. And so for patients with Stargardt's, so with either a clinical phenotype or picture of Stargardt's, so when we look, it looks like Stargardt's, or they've got a confirmed genetic change in that ABCA4 gene, we do advise avoiding vitamin A supplementation. So we all need vitamin A in our diet. You know, if we don't have any vitamin A, then that causes problems. Vitamin A deficiency is a big cause of, is a big problem worldwide. So it's not, but, you know, dietary vitamin A is still important, even if you have Stargardt's, but just not over and above, because vitamin supplements tend to have 100, 200 times the recommended amount of vitamin A, and then it's harder for your body to process that.
Yeah. And so we had an interesting question that sort of tacks onto the back of that. Should people with Stargardt disease avoid using skincare creams containing retinol because of that link to vitamin A, or are the amounts really just far too low to worry about that would be absorbed through the skin?
So we know that most of your vitamin A is absorbed from your diet. So really kind of 95 to 90% of vitamin A is dietary absorbed. And, you know, there's minimal absorption of vitamin A through the skin. There is some, but, you know, very little. And really on balance, there's no evidence. Nobody's really done a clinical trial of looking at these things and how much is absorbed and what the levels would be. But given that we need some vitamin A, I think probably, you know, a vitamin A, a tiny bit of vitamin, because it is a very small amount in these creams, generally is probably fine. But if you are taking, you know, a retinoid drug for acne or something like that, then obviously that's different if it's oral, and then that I would speak to your, you know, GP or doctor looking after you for those purposes before going down that route.
Thank you. Change of subject. So what progress, and this is always a popular topic, what progress is there regarding stem cells and stem cell based treatments? How far away are we from stem cells being used to replace degenerated retina?
So as I'm sure this audience kind of knows very well, stem cells have been looked at for quite a long time now, essentially because theoretically they're the ideal solution. So you have a population of cells in the retina, either rods or cones or both, that's not working so well. And so as those cells become less healthy and either stop working or die away, if you could use stem cells to replace them, then, you know, in theory, that is the perfect way of restoring your vision. The problem, you know, we have in the lab and in research is twofold, really. One is getting those cells to survive. So if you take an external group of cells and put them in the retina, you know, they have to be there and stay there for a long time to have an effect. So that's one thing. And the second thing is they have to talk to the other cells within the retina, because there's no point putting in a nice new layer of cells if that's not going to connect to the next layer, because really vision is a pathway. You have your rods and cones that detect the light, but they then feed the signal into the next layer of cells, which then, you know, cascades up, and really it's, you know, that signal has to get to the brain for you to be able to see. So so there have been, you know, a number of stem cell trials, both for age-related macular degeneration and a few for inherited retinal disease. But really, out of all the potential therapies, stem cells are probably the furthest away from actually coming to the clinic, just because of all those challenges I've mentioned. It's, you know, safety, getting them to survive, will they talk to other cells? It's all been quite challenging, from even if in the lab in a sort of mouse model or that kind of very controlled environment, it seems very promising. It's much harder to do in a person or so on. So there are multiple teams around the world. You know, there are companies that are starting stem cell trials as well, that, you know, in early stages, looking at safety studies. There have, you know, been a few along the way, as we know, and AMD also, one of those studies recruited Stargardt patients, but overall there's not, there's still quite a long way to go in terms of getting there.
I wonder if it's worth mentioning at this point, just for this, to avoid any confusion, that there is a company, J-Site, who are doing, in the middle of trials at the moment, and talking about starting a phase 3 trial, who are injecting a cell-based therapy into the eye, but they are not, they've quite clearly said they're not aiming to replace retina that's already gone. What they're trying to do is support and nourish the remaining retina.
Absolutely. So there are two ways that you can use stem cells for therapy. So what I was talking about is replacing cells that have gone. So once you have vision loss, can you restore vision by replacing those retinal cells? But another strategy is what you've just mentioned. So stem cells, or, you know, cells in the retina produce lots of different factors. There are lots of growth factors and neurotrophic factors that help the retina to survive. So another way of doing it, or another sort of avenue of therapy, is to inject stem cells for that purpose, not to sort of connect with the remaining retina and form sort of pathways, but more to just release all those nutrients and nourishing factors to try and promote the health of the surviving cells.
Yeah, so that's really aimed at people who haven't lost all of their vision yet.
Yeah.
Off the back of that, somebody's asked, what's the likelihood of a treatment that can significantly restore sight in the next 10 years, or is that further off? I think you've kind of partially maybe answered that question, but I know it's really hard to put a timeline on things.
Yeah, so I mean, there are a number of different ways of approaching sort of vision rest, in an ideal world, complete vision restoration, but at least some improvement in vision. So one is stem cells, as we've already mentioned, but the two sort of other broad areas that people have been researching for a while now are retinal implants and also what we call optogenetics, which is a form of gene therapy to try and restore vision. So again, with retinal implants, there have been multiple clinical trials, both looking at inserting a chip, an electronic chip underneath the retina or on top of the retina. So to try and electrically stimulate the cells that are remaining to try and restore vision and a visual function. And both of those approaches in clinical trials did show good outcomes. So they did show improvements in vision and some improvements in visual function. So that's the original companies that started those trials are no longer functioning at the moment, as far as I'm aware, but other trials are starting up or ongoing looking at retinal implants. So that is one thing. And then the other avenue of research is, as I mentioned, sort of optogenetics, which is a type of gene therapy. So essentially, normally in gene therapy, what we associate is replacing a specific gene. So somebody has a variant or a change in one gene that's causing their eye disease, and then you replace a healthy copy of that gene. Whereas in this form of gene therapy, it's more aimed at patients with more advanced sight loss, so who've already lost a significant amount of vision. And what you're doing is you're introducing a light sensitive protein into those remaining cells. So to try and make the retina that's left work like rods and cones or be light sensitive when that normal infrastructure is lost. And there are a few now. I think there are 4 clinical trials ongoing for optogenetics. So that seems to be one of the ones that's kind of moved a bit in the last few years. And there's a trial that's run jointly between Moorfields and, it's led by a French team, but they also recruited some patients from Moorfields, and they published outcomes from their first patient in Nature Medicine last year, I think, and showed some visual gains, some improvements in visual function using specific tests, so kind of ability to identify objects on a table or kind of broad parameters of vision. And that also, as well as the gene therapy, involved wearing a pair of glasses to sort of augment or enhance that stimulus of light to really target one wavelength to get that protein that was introduced to work. So potentially, I think, given that there's a lot of commercial interest now in optogenetics, there's a lot of money and effort and time being pushed into it. I think that is something that we could see results from sooner rather than, potentially sooner than some of the other therapies. But also retinal implants, if, the programs can get going again. We know that the previous ones did show promise. So it's trying to push those things further.
And it's exciting that actually those things are all not gene specific, which obviously has some advantages, because hopefully a really large proportion of our community would be able to benefit from those. Just before we move on to the next question, just a reminder, if you have a question, please could you type it into the Q&A box in Zoom. We're unfortunately unable to respond to a raised hand this evening, so if you could type in your question, that would be really much appreciated. So moving on to a topic a little bit more about genetics and the practicalities of inheritance. So questions come in. I have 2 sons. One has RP, one does not. They in turn each have children, and I'm concerned about my grandchildren's risks of inheriting the condition or carrying it to pass on to future generations. What's the best way for us to understand the risks for each individual in the family?
So I completely appreciate, the question. It's one that we get asked a lot, and I think when patients come or people come to clinic, it's one of the things that, you know, is top of the list of things to ask. So the first thing is really to understand the inheritance of the retinal dystrophy. And sort of in broad terms, there are 3 or 4 different ways that genes can be inherited. And so from the scenario that's given, it's difficult to tell what that inheritance would be, because essentially what we would do in clinic is take a, you know, draw a family tree. So try and work out if there are any other members in the wider family. So that could even be parents, grandparents, aunts, uncles, cousins, you know, all of that information is actually really important. So to try and, you know, ascertain that, and then based on what we see in the rest of the family tree and the pattern of disease clinically, we can often sort of estimate or suggest a mode of inheritance. But the only way of really knowing that for sure is genetic testing, if we're, you know, able to do that. So broadly, just to sort of think about inheritance, there's autosomal dominant disease, recessive, and X-linked, and sort of what that means, to not go into too much sort of technical detail, but from every gene in our body, we inherit 1 copy from mum and 1 copy from dad. And for dominant diseases, you only need 1 of those copies to be affected. So either the gene you've inherited from your mother or your father. And that means that any children would have a 50% risk of being affected. So, you know, 1 child, if you have 2 children, you know, each has a 50% risk.
Yeah.
Autosomal recessive conditions require both copies of the gene to be affected. So the one you inherit from your mum and the one you inherit from your dad. And in those situations, there tends to be less of a family history. So it tends to be, you know, not so common in other family members, although in certain situations it can, you know, you can see other family members. But in that case, it's really, you know, your children would need to have 2 affected copies of the gene. You would, they would inherit 1 from the affected individual, so they would definitely be a carrier, but we generally quote the risk of them being affected as less than 1%, because we don't know what, you know, their your partner's genetic makeup is, and so on. So and then the other is X-linked. So our sex chromosomes, we have an X chromosome and a Y chromosome. So if there are genetic changes on the X chromosome, then, you know, sons, if it's a it sort of gets a bit complicated. I don't want to sort of get bogged down in the detail, but if a male is affected, then their sons will not be affected and their daughters will be carriers.
Yeah.
So it's all kind of dependent on multiple things. So it's hard just to say from a scenario of an individual what their risk is, because it's dependent on, you know, all of these different things that we're talking about. But like I said, from the family tree, you can ascertain a certain amount, but really genetic testing is what we would advocate to know in more detail. So what that involves is a blood test, which is sent off to a central lab. And essentially what we do is look at, or what they do in the lab is look at certain genes primarily, which we know are associated with retinal disease, and look at changes in those genes. And it can be quite hard to interpret, because obviously we're all genetically different. That's what makes me different from the next person. And it's about interpreting those genetic changes in the context of what you're seeing clinically. So it's not as simple as sort of doing a blood count and putting it in the machine and getting an answer out the other end. There's quite a lot of complex processing, and then any changes you see have to be validated with what's been published before, what's known, etc., etc. So really in adults, we sort of normally quote a sort of 50 to 60%. It can be a bit higher, or it sometimes can be a bit lower, but about sort of a 60% positivity rate from doing genetic testing. So in about almost 2/3 of patients will be able to find a result, and in about 1/3 of patients we won't. And that's either because the technology hasn't been good enough to sequence every single bit of the gene, or that we just don't know about those genetic changes yet. So generally what happens then is that blood is stored in the lab, and as new discoveries are made, as new reports are made, you can always go back and visit that to try and understand things further. But if we can identify the gene, then that gives us a much more, well, gives us the ability to counsel much better on risk to children, because we know in general then how that gene behaves and, you know, what we would expect to see.
That's really useful, actually, because that links to another question you've already sort of answered, which is I've had genetic testing and there is no result, and why can't it be identified? So you've kind of covered that. The person said we've got children and grandchildren and no idea if it will pass to them. Even though the genetic test hasn't given a definitive result, would a genetic counsellor be able to support in that scenario and perhaps help the person know a little bit more about risks to other family members?
Exactly, and that would be really important. So I would definitely advocate reaching out to the team and asking to speak to the genetic counsellor, because, like I said, based on family history and how the eyes look and what the disease looks like, we can sort of sometimes give a fair impression of what we think the inheritance might be. So there's always surprises, but in general, you know, you can advise. So I would definitely, you know, ask for support, and the genetics counsellor of the team who did the genetic testing should be able to do that.
Okay. And in case there's anybody on the webinar who would like to know more about how to access genetic testing and genetic counselling, we have got some information on our Unlock Genetics website, which you can access from retinauk.org.uk/genetics. And there's lots of information on there about genetics, inheritance, but also ways of accessing testing and genetic counselling. So do have a look at that. Bit of a change of topic. So I have RP as a result of Usher type 2. I know a lot of research has been done on RP, and we would all like to see a cure as soon as possible. However, it seems to me a lot of eye problems come from having cataracts. I personally have had cataract surgery in both eyes, and this has been followed with edema and PCO needing laser treatment. My question is, why are cataracts prevalent in RP? And is there any research on how to prevent cataracts?
So it's a very good question. And as with a number of things, you know, with eye disease in general, really, we have no exact answer as to why cataracts do seem to be more, or are more prevalent in people with RP. It's definitely something we see not uncommonly. So you can develop cataracts at an earlier age, and there are certain different types of cataract, and it's one particular type that we often see associated with RP. And you know, there's no exact answer as to why that happens. The theory is that there's some degree of inflammation within the eye as a result of this degenerative process that's going on from the loss of rods and cones and lack of cells. And the kind of hypothesis is that inflammatory component may bring on cataract earlier, because we do see cataract in other types of inflammation or so on and so forth. But you know, there's no exact mechanism that's understood, or you know, anything I can say more clearly than that. In terms of how to prevent, in RP in particular, there is no, you know, nothing's been studied as to how to stop cataracts from forming. But just generally, as per sort of all the eye health advice, we know smoking can accelerate cataracts, so definitely don't smoke. There is some evidence that ultraviolet light can be bad. So again, it's just kind of all the usual eye health
Same things.
Yeah, exactly. It's nothing specific, but just, you know, eat well, don't smoke, and you know, UV protection.
Cataracts, there was an add-on to the question that I didn't mention actually. Is there any possibility that in the future there will be a non-surgical treatment for cataracts, or are cataracts purely a very sort of physical, need removing type thing?
Yeah. So I think obviously, if, you know, as with anything, it would be nice not to have an interventional procedure. But so if we imagine the eye's like a camera, a cataract is the natural lens in the eye that's gone cloudy over time. So really what we do at the moment is remove that cataract and put a new lens in its place. And because it's really such overall, I mean, I know people have complications. Well, you know, the person who mentioned they had PCO which needed lasering, or they might have developed macular edema which might have needed further treatment in terms of drops or so on. Generally, it is a very successful operation in terms of, you know, it's the highest surgical volume procedure done on the NHS. I mean, it's really something that is generally very successful. And I think for that reason, the research into looking at other ways of doing it is less so than with other things where we don't have a therapy. And there's always advances in terms of how we can do cataract surgery better. So there's laser procedures that can be done at the time of cataract surgery. That's being explored. There's sort of ways of making it more efficient. You know, the machines and lenses and all that aspect of things are advancing every year. But in terms of actually trying to get rid of an operation in its entirety, I think is probably quite far away.
A bit too tough, for now. Let's actually, one more question about sort of, I suppose, sort of treatments. Can you tell us any more about infrared light therapy and whether this could be beneficial in inherited retinal disease?
So as the majority of studies looking at infrared light therapy have really been for early or dry age-related macular degeneration. So looking at, and there are some now high street, both optician, optometry practices and private practices that offer light therapy. So it's got a long name, photobiomodulation, sorry, name that escapes me at the moment I need it, where you wear a light mask for a certain period of time, you know, and have regular treatments with that. And really, as I said, it's been investigated the most in age-related macular degeneration to try and slow down the progression of early AMD, so before it kind of impacts significantly on vision and vision loss. In inherited retinal disease, as far as I'm aware, and there are things changing all the time, but there hasn't been a big trial that I'm aware of, but that's something that I'm happy to look up. And even in AMD, the evidence is a bit mixed. It's a bit unclear. It's not like we're going around advocating that people do this, but there are some trials that have shown potentially some positive results, and I think they need further validation. It's not something that's available on the NHS, and it hasn't sort of gone through that regulatory process. So from the infrared kind of therapy, that's what I'm aware of. On the flip side, in RP, there are lab-based studies which look at light toxicity, because we know that, as we've talked about, you know, light can be harmful to the retina, and there have been in mice and other, you know, very laboratory-based research programs, some evidence that cutting out certain wavelengths of light can slow down progression. So it's another one that is, you know, the jury's out a bit on. We don't really give any specific advice, or because there isn't really the evidence base to back it up at the moment.
Okay, thank you very much. Let's go back a little bit more to research. Firstly, we've had a question actually in the chat this evening, which is quite nice, and a specific one about a specific research technique. Are there any CRISPR trials ongoing for reversing or halting sight loss. So CRISPR is a gene editing technique where you can go in and actually change the gene, correct it.
Absolutely. So there is, it is exciting in that, you know, the retinal disease is one that CRISPR trials have, or a CRISPR trial has started in. So there's a company called Editas who leads this trial, and it's for a specific gene, the CEP290 gene, which often causes very early onset retinal dystrophies or retinal problems. And it's not just specific to the gene, it's specific to a particular genetic change within that gene, because as Kate mentioned, the premise of CRISPR is you go in and you, rather than in gene therapy where a gene's not working, you replace a healthy copy of that gene. In gene editing techniques, you correct the native sort of DNA, you correct the bit of the gene that's not working. And so what you have to do is introduce a small segment with the right sequence in. So, you know, there's, rather, when the bits of the gene are, the sequence isn't correct, you sort of introduce that correct element to it. And so it's very specific, but there is a CRISPR trial ongoing for CEP290 variants, I think mainly in the US. There might be some other sites. And they did release a press report, I think, on the first few patients showing safety. So, you know, with any clinical trial, the first thing they look at, well, in a phase 1 trial, is safety. So you have to make sure that anything you're trying doesn't cause any adverse effects. So it's well tolerated, there's not a lot of inflammation or problems in the eye by giving it. So, you know, that's very, you know, positive that they showed good safety data from the initial few patients, but we're still waiting to know more and to see sort of a bigger cohort of patients coming, you know, results from them coming through.
And I suppose there is a challenge associated with the fact that it is so specific. So you've got to really drill down into your own genetic diagnosis to know if you would ever be eligible for that particular treatment, because it's dependent not only on the gene, but also the type of change within that gene. So just to talk about that briefly, that is a challenge, isn't it? In inherited retinal disease, we've got all of these different genes, and so many treatments appear to be coming through that are so specific. Do you think, which way do you think it's going to go generally in the future? Do you think it's more likely that people will end up being treated by something that is not specific to their own gene?
I think there's a role for both, obviously, because as we've said, about a third of patients don't get a genetic diagnosis at the moment. And so for those patients and for those others who present with sort of already relatively advanced vision loss, the therapies that are not specific are going to be the ones that are suitable, or the only ones that are possible, really. And so and also, given that those therapies are not specific for a gene, they're much more applicable to different people. And for that reason, companies are much more interested in funding them, because one of the challenges we have is you can do so much in the lab, but to get a therapy to patients, it needs a huge amount of investment, and then that gets driven by the commercial sector and pharma. And so if there are therapies that are more broadly applicable, they tend to get pushed a bit, you know, further. Saying that, things like CRISPR, which are very, you know, cutting edge, very novel, very high impact, also get driven because they, for all those reasons that people want to, you know, show that they can demonstrate things, because if you can do it in one disease, then potentially you could do it in multiple diseases, and then that again opens up the, you know, applicability from doing it in different settings. So so it's kind of two different populations, because if we can treat in a specific way, you can stop things getting worse, or potentially stop things getting worse. But the non-specific treatments or the less specific treatments apart from the caveat of the stem cells we talked about earlier, giving, factors to promote retinal health, most of the other non-specific treatments tend to be for restoration of vision once it's already been affected.
So that leads quite nicely on to some questions, some general questions really about driving research progress and how we can facilitate research progress. So somebody's asked, what can we, people living with sight loss, friends and family, do to help you and other researchers? For example, writing to MPs about funding or taking part in studies, anything like that.
So obviously all help is very welcome. So thank you for the question. I think on a personal level, we taking part in research where possible and where you feel comfortable is fantastic, because as I've discussed, there's a lot, a big lack of evidence for even some of the simple questions out there in terms of retinal disease or inherited retinal disease. So taking part in studies where you can, even if it's what we call a natural history study, looking at just how the disease progresses over time, because sometimes we don't even everyone's so different in a lot of retinal conditions, that actually having that broad width of knowing what the spectrum is really important in developing therapies, because if you develop a therapy, you want to know what response you're expecting to see. And when there's so much underlying variability, that can be quite difficult. So, there are several groups doing natural history studies just to follow up over a period of time as to what changes and how it changes. And even taking part in something like that is incredibly useful from a research perspective. And obviously for some conditions, there are also a few clinical trials. And funding is always a limiting factor, and unfortunately, if we look at eye disease, ophthalmology probably only gets about 1% of research funding, of all medical research funding. So it's really underrepresented, given that eye disease is quite prevalent, and in ophthalmology as a whole sees a lot of patients in the NHS. So any sort of support with funding, fundraising, all those kinds of things is also incredibly important. And highlighting issues to people, people who have the power to change some of these things, like MPs, is obviously great as well.
So that just gives me an opportunity to mention actually that if you are listening tonight and you are interested in taking part in research or just getting involved in studies, Retina UK has a lived experience panel, what we call a lived experience panel, which is an ever-growing group of our community who have said that they're particularly interested in taking part in studies or in supporting researchers in their work. And you are all incredibly welcome to join that. There's more information on our website about that, and we can tell you when researchers ask us or tell us that they're looking for people to take part in surveys and things like that. So do get in touch with Retina UK if you'd like to know a bit more about that. And talking of funding, somebody's asked, would unlimited funding make all the difference to finding effective treatments, or are there other limiting factors like skills, human resources in the lab, the way the technology is moving forward, and even the healthcare infrastructure that's needed to deliver the treatments when they're developed?
So absolutely, it's a complex process, and there's no answer that if you sort of solve this bit, that everything will fall into place magically, which would be the ideal solution. But I think what COVID showed us was that if there are enough people working on something and there's enough momentum and backing from the powers that be in terms of regulatory authorities, commercial entities, pharma, drug companies, things can be pushed forward faster than they otherwise would be. So, you know, normally from developing a vaccine to getting it into people's arms, it takes the best part of 10 years, whereas obviously they did that, you know, in under a year for COVID. Not to say that everything was done from scratch. A lot of those, the platforms for doing so were already in place, but the point is that, you know, if everyone's kind of driven in the same direction, you can achieve things quicker. So, you know, that does help, but there are things that we don't know yet, and so the laboratory research and discovery research is really, really important. And also just there are problems that still need solving. So even if you have a gene therapy, some of the gene therapy trials so far that have been very successful in the lab don't seem to have shown quite as positive results in patients. Why is that? We don't know. More research is needed to understand how we jump from the laboratory setting to the human setting. There seems to be certain, you know, barriers that we still don't understand. And so it's really on all fronts. We need to keep pushing, keep striving ahead to, you know, try and unlock some of those mysteries, really.
Thank you. And going back, we've got quite philosophical there, really. So let's go back to a few sort of slightly more clinical and specific question. Actually, we've had a question about cone rod dystrophy. So can you give us any updates generally on cone rod dystrophy research? Is there anything out there yet that might improve or maintain central vision? If somebody's diagnosed with cone rod dystrophy in early childhood, does that central vision loss tend to continue to progress throughout life? Does it plateau? Is peripheral vision preserved? Can you tell us a little bit more about cone rod dystrophy and what's going on?
So again, it's the difficulty we have with inherited retinal disease is it can be very different between different people, and even within the same family we can have different people whose vision changes sort of are quite disparate. But generally so there's two conditions. There's cone dystrophy and cone rod dystrophy is the start. So it's one whether they have one or the other. So a cone dystrophy, and the way you tell them apart either is you can tell looking at the retina sometimes, or otherwise doing electrodiagnostic testing. So essentially you stick lots of electrodes around the eyes, or even you can test the visual cortex as well, show lots of patterns and pictures and see how the electrical responses from the retina arise from that. So if you have a cone dystrophy, that tends to then be localized to your central vision. And so the central vision would be affected, but you would expect that peripheral vision, so navigational vision, would remain intact. A cone rod dystrophy is a slightly different thing, where you have predominantly the cones affected, but also some of the rods affected. And those can be a little bit more progressive in that you can have even though the predominant symptom is central vision, there can be a little bit more peripheral involvement that progresses. So it's hard to answer the question kind of without knowing specifics of what the eyes look like and what other tests have been done and how to interpret. But generally, from the central vision side of things, if someone was diagnosed very young in childhood, by their sort of 20s or 30s, it probably would have plateaued out in terms of the central vision loss.
Okay. And is there any research sort of specifically looking at cone rod dystrophies?
So cone rod dystrophies is kind of an umbrella term for, so rather than RP or rod cone dystrophies, where the rods are affected, the peripheral vision's affected first, cone rod dystrophies are the opposite, where the central vision is affected first. And again, it's dependent on the gene that's associated. So you can get cone rod dystrophies, for example, associated with ABCA4 Stargardt's, and in that case then there's a huge amount of research being done, but some of the rarer genes or less common genes, then people are looking at them, but there probably is less sort of less different strategies being looked at. So again, it's partly dependent on the genetics as well.
Sure. If you're listening and that was your question, do get in touch with us separately. I'd be really happy to have a more individualized conversation or email exchange and try and find out a bit more for you if you would like to. Can you tell us how familial exudative vitreoretinopathy is diagnosed? Is it always picked up by genetic testing? And if not, can it still be clearly diagnosed from clinical tests?
So, yeah, FEVR or familial exudative vitreoretinopathy tends to be your primary suspicion is clinical for it. So, essentially, often in children or in younger adults, or very occasionally presenting later in life as well, you see a particular pattern of retinal disease which would make you think that this is FEVR. And then based on that, you would do genetic testing. And just like in RP, genetic testing in FEVR, there are several genes that are associated, but positivity or genetic testing tends to come back with a result in about 50% or 50 or 60% of patients. So it's not based on that genetic diagnosis alone. It's more the clinical appearance, and then that's confirmed or validated a bit more with genetic testing.
Okay, so if you don't get a result, it doesn't mean it's not FEVR. Okay.
Yeah, exactly.
And we've also had a question about adult onset vitelliform dystrophy. Is that's different presumably, and how common is it to find a gene in that?
So adult onset vitelliform dystrophy can be genetic. So the problem sometimes we have in eye disease and ophthalmology is people use terms in different ways. So a vitelliform lesion is sort of a yellowish lesion in the macular region. And that can be associated with certain genes like BEST, the BEST1, the gene for Best disease, or another one called PRPH2. So they can be associated with adult vitelliform dystrophy. But that clinical picture of those yellowish lesions in the macula can also be associated with AMD, with age-related macular degeneration. And so the genetic testing success rate in adult vitelliform dystrophy is much lower because you've got often an older population who are susceptible in the age group that are susceptible to both AMD and a dystrophy, and clinically it's often very difficult to tell the two apart. So the result, the chance of getting result actually falls off quite a lot when you're looking at that particular group. There are certain features, or if there's a strong family history or certain things that might mean that you're more likely to find a gene, but because of this overlap with AMD, it sometimes gets quite tricky.
Okay, thank you. We've had a really interesting question in the Q&A box, Sam, and it's actually a question, sounds like it's from an educator, and I don't know if you'll know the answer to this or not. So apologies if this is sort of outside a clinician's remit, and we can do what we can outside the webinar to find an answer if so. But somebody has said, I support a pupil with RP. She's the first pupil I've supported with this condition. Coloured paper and overlays are helping her with her work. Do you know if coloured lenses can also help?
So it's a good question. I wouldn't be able to give a specific answer. There is some evidence looking at coloured lenses. Actually, I think there was a Cochrane review that was published just in the last few weeks looking at coloured spectacle lenses I don't think it was specifically in RP or retinal dystrophies, but just with retinal disease in general. I think, there are certain benefits in terms of reduced glare, and especially now that so much of schooling and work is computer-based, then that obviously can help a lot. But there have always been some concerns about whether it would affect contrast sensitivity and that sort of thing. What I would advise is speaking to the sort of local low vision specialist or optometry team who deal with those specific clinics, because they tend to be the most experienced as to what they would recommend for different groups of patients. So sorry, I can't give more details than that, but there is some, certain patients definitely benefit from it, and it might just be with some of these things, it's just a matter of trial and error, just to see, there are different coloured tints, so yellow or a pinkish rosish coloured tint, and sometimes it's just a matter of trial and error as to working out what suits someone best.
Thank you very much. And we very much consider QTVI as part of our professional community. So if you're listening and you'd like to talk to us a bit more about supporting an education, then do let us know. I think we're quite close to running out of time. One very quick last question is, are inherited retinal diseases ever misdiagnosed as retinopathy of prematurity?
So generally not. Generally, the clinical picture for things like RP or macular dystrophy would look very different. FEVR is the only one that could look similar, and there can be a bit of overlap in terms of, or quite a lot of overlap in terms of how it looks clinically. And so you would go with certain features in the history. So essentially, FEVR tends to present a little bit later in childhood, often, not always. Babies with ROP would tend to have a history of prematurity, and if that were the case, they should have ROP screening as part of their neonatal care. So often, if in those settings, things can be differentiated based on all the other things going on. But occasionally you do get sort of older children or adults presenting with milder ends of those, of those conditions, and it can be hard to know, especially if you don't know what their neonatal history was or whether they were premature or any of those sorts of things.
So we have reached the end of the time that's available. Thank you so much, Sam. We have got through a lot of our questions that were sent in, but if we haven't got to your question, please do let us know. We'll do our best in the next couple of weeks to get round to everybody else. So yeah, again, a huge thank you to Sam. Thank you to everybody who's joined us this evening. As I said at the beginning, we do hold a webinar in most months. Over the next couple of months, we've got webinars on access to work, and one on the use of artificial intelligence in diagnosis and research, and details of both of those are on our website. Retina UK is a registered charity, as most of you know. We receive no government funding and rely on our wonderful supporters to raise the funds needed to provide vital services and invest in research. There are a few ways you can support us in the coming months. Christmas cards, dare I say it, are now available in our website shop. We have some exciting events and challenges. So Halloween and bonfire night skydives have got limited places remaining. These are taking place at airfields around the UK on the weekends of the 28th of October and the 4th of November. We've already tried to persuade Sam, but she's not having any of it. During the new series of Bake Off, we're running our Great Bake campaign again and asking our supporters to organise their own bake sales. If there are any keen runners out there, we've got places in the 2024 half and full marathons for Paris and Barcelona. If you'd like information on any of those, please contact my colleague James Clark, via james.clark@retinauk.org.uk, or simply call the office and ask to speak to a member of the fundraising team. And keep an eye out for our annual raffle and the Big Give Christmas Challenge, which are also coming up. We'll be sending out an email over the next couple of days, which has details of where you can re-watch or listen to tonight's webinar, and details of how to book on to upcoming events. We'll also be seeking your feedback on today's session. We really value your feedback. It's really important to us to help develop our webinars and other services. So thank you again for joining us this evening. Thank you, Sam. Thank you all for your great questions, and we will see you again next time. Bye for now.